welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, hello, hello. Happy Monday and welcome to Brain Chat. It's Dr. Mitzi, the nerdy neurologist, and I am so excited to be back with you guys. I don't know, it's only been 2 weeks, but I feel like it's been forever since the last time we had Brain Chat. And we have got an action-packed episode today. I am so excited to have these wonderful guests on with me today. You guys know how we do when you log onto Brain Chat. Log into the chat, type in and tell me where you're viewing from. I bid you greetings from Atlanta, Georgia, where it is super hot. We're getting in the 90s. So, it's about to be a very brutal summer here. So I hope everybody's staying cool. And I hope that for those of you who are moms, that you had a wonderful Mother's Day this weekend, and that you all got some time to rest and relax. All right. So we also want to thank our sponsors, Bioidentical and the National MS Society. All right, so let's get into it because we have got a lot to talk about today. All right, so we'll start with our bios for our guests. We have the wonderful Dr. Riley Beauvais, who's an associate professor of neurology at UCSF, director of digital innovation at the UCSF MS Group, and she is also a practicing clinician. She obtained her BA from Harvard College and her MD and MMSC degrees from Harvard University. She did her internship residency and neuroimmunology fellowship at Mass General Brigham. She does research on sex and gender-informed neurology, and her research has been funded by the NIH, the National MS Society, the California Initiative to Advance Precision Medicine, the Hilton Foundation, and industry. And she's had early Fulbright work on social determinants of women and children's health in West Africa, and currently is working on research concerning caring for women with MS during pregnancy and the menopausal transition. So she is well equipped to talk about today's topic, which is women's health and MS. And we also have Megan Vignos, who's obtained her PhD in cellular and molecular biology with a focus on neuroscience through a joint program with Kent State University and Cleveland Clinic. Her research focused on radiological and histological characterization of myelocortical multiple sclerosis. She then moved from academia into industry with a medical science liaison position with Bioidentical for multiple sclerosis. She has been promoted to senior medical science liaison, associate director, interferon lead, and finally, she now is the U.S. medical director, MS franchise, and interferon lead. And when she's not busy with work, she's hanging out with her husband and her 2 kids, playing board games and doing all the fun stuff that hopefully many of us got to do on Mother's Day. Welcome, ladies, to Brain Chat.
It's so great to be back with you, Mitzi.
Awesome. And thank you, Megan, for taking your Monday night out, to spend some time with us.
Well, thanks for having me.
Absolutely. All right. So let's get into it. First question I always ask, how did you get involved, or what attracted you to get involved in the MS space? And we'll start with you, Megan.
Sure. Thanks, Mitzi. So actually, I have an aunt that has MS. And so when I was in, undergrad, I was very much interested in kind of, how the brain worked, how it functioned, but then also how it didn't work when you have a neurological condition. And so I just kept kind of getting pulled and drawn in towards MS. And ultimately, that's where I landed for my PhD work.
Wow. Amazing. Riley?
Yeah. And I've always loved neurology and sort of thinking about how the brain works and how our brain health is sort of shaped by, our families and our communities and our cultures and environments around us. And what I really love about multiple sclerosis is you can just form these really long-term relationships with patients where we're really with patients at like all these key times in their life, not only sort of their MS diagnosis, but also through a lot of life transitions, having starting families, going through menopause, changes in life. And I think it's just really wonderful to be able to partner with patients during all these important times in their lives.
Awesome, awesome, awesome. Well, thank you all for that. So this is a broad topic and it's going to be very difficult to cover in the time frame that we have. But I want to try to touch on a couple of things and to really just kind of talk about the different needs of, pertaining to women's health across the lifespan, as well as specifically to multiple sclerosis. So let's just kind of think about it in the broad sense, the 50-foot view. What are kind of the different transition periods that we need to pay attention to in women's health that may, where we need to pay extra attention to either their medications or their treatment course, across the lifespan? And I'll start with you, Megan.
Sure. Thanks, Mitzi.
Mhm.
So I think it ultimately starts as early as childhood, right? I mean, we have to start with teaching children good habits about diet and wellness, so that way they can carry it through their lifespan, right? And then as they transition into adolescence, helping them kind of understand what's going on with their body, because they do experience a lot of changes, and really appreciating what their body is going through and how that's going to be managed through, all of their time up until they go through menopause. And then, as kind of Riley said, as a woman continues to in their journey of life, they could be possibly family planning. And so understanding, what does that mean? Again, how do you change diet? How do you potentially have to change wellness? What are the different considerations for what you can and cannot put into your body during that time phase? And then again, moving on to the, menopause period, understanding yet again another set of changes that the body is going through, and how those hormone changes play into all the systems. It's not like it's just your sex organs that are going through this impact, but across the whole body, and what that means for the patient over the long term. And then even into kind of the elderly phase, again, there's a whole new, world when it comes to how to take care of your brain during, that time period, to reduce risk for all types of different dementias.
Absolutely. So important, and I guess I didn't really think about these transitions when I was younger, but the more mature I get, the more I'm thinking about
The more you make
different.
it through some of them.
Exactly. The more I've been through some of the transitions and anticipate some of the other transitions, and I think that this is really important because even though MS has been disproportionately affected by women, affects women, there really hasn't until recent years been as much attention, to how do we practically treat MS across the lifespan? What are the changes that occur during pregnancy? How do we treat people? It kind of was, just take everybody off their medicine and let's just see what happens, And so now we're learning more. And I think this is really exciting because we can make more informed decisions with our patients about how to make sure that we are maintaining their brain health and keeping their MS at bay while enabling them, to also family plan and to get their family started. So let's transition and talk a little bit about family planning. So Riley, if you could kind of start us on this conversation about kind of how you've seen that transition and about some of the research about what we know now about treating women during pregnancy.
Yeah, great. So just want to add a couple things. I think that, we want to make sure that our male patients don't feel neglected just because we're focusing on women's health today. And we also want to make sure that we sort of call out the fact that we're typically talking about sort of, cis women, and the LGBTQ considerations also need a lot more attention. But focusing now on our cis women who sort of our biological females and who might be thinking about sort of pregnancy and family planning, I think it's really important that we keep in mind that life changes and that people's feelings and biology and plans and awareness change. So it's really important that when we are caring for someone with multiple sclerosis who might become pregnant, at every visit, we touch on the possibility of, their intention about getting pregnant in the next year or two. It used to be that we told patients that they should not have pregnancies after an MS diagnosis. And I still do see patients who might be in their 50s or 60s who were told this by their neurologists. We now know that that's just not true, that patients with MS should probably plan to have the family size that they would want to have, sort of not considering sort of pregnancy management questions. So I think that's one key message, that we can really support patients in thinking about the family that they want to have. I think the second message is that we don't have an excuse anymore not to think about the potential impact of medications on a pregnancy.
Absolutely.
So whenever we are starting medications, the possible safety during pregnancy has to be on our minds. And so whether that means we might not start a medication if that has rebound discontinuation effects, meaning you stop the medication and the patient's MS flares right back up, we might not start that kind of medication if we know we're going to have to stop it in 6 months or 12 months because the patient wants to have a pregnancy. So we have to plan the medications carefully. And then the other thing is we have to make sure that our patients are in their best wellness overall. So thinking about not smoking, or thinking about diet, thinking about mental health and social support, all the kinds of things that we can sort of tee them up so that at the time that they might want to, consider a pregnancy, they're all teed up and ready to go. So I think there's a couple areas where we know a lot more than we did before, and we can really help our patients through the pregnancy transition really smoothly.
Absolutely. I mean, you said so many good things and kind of touched on what Megan was talking about a little bit earlier about, brain health, right? So we want people to be in the best place possible, in terms of their neurologic reserve, keeping their brains good and healthy so that, if or when they encounter some issue, they will have kind of built up that reserve and they'll be engaging in those healthy habits, whether it's diet, exercise, meditation, mindfulness, stress reduction, all of those things. So when we think about, family planning, we think about pregnancy, we also think about breastfeeding, so there's been a really big push, I think, in our society to focus on breastfeeding because it's healthy for mothers. I have 2 kids and it was a struggle for me to make it to 6 months, you know what I mean? And I did not have a chronic neurologic condition. But certainly there is a desire for many of our patients to breastfeed. So how do we kind of navigate those issues as well? Are we learning more about how our disease modifying therapies affect breastfeeding as well?
Yeah, so it is such an evolving question, and it's so important. So again, not every postpartum person wants to breastfeed or can breastfeed, and it's not the right choice for every baby. But a lot of times, breastfeeding is part of a self-identity as a mom. It's part of the maternal role, and it's something that, as you said, Mitzi, has really good health benefits for the mom in general, in terms of
Makes you skinny.
losing that postpartum weight. Also sort of, risk of diabetes and things like that. It's also, of course, excellent for the baby in terms of both bonding, infection prevention, and long-term health. But in MS, we also know that breastfeeding prevents postpartum relapses. And so there's so many reasons why it so many benefits that it has. And so the key is, can we move from the conversation where moms have to pick breastfeeding or MS therapy
Mhm.
postpartum to a conversation where they can breastfeed if they want to and go back on a medication. Because we know that postpartum relapses do exist. That is basically the highest, it's that time period in an individual's life probably where they're at the highest risk of relapses after
Mhm.
diagnosis is postpartum. So we want to do everything we can to protect our patients from having relapses at a time where they have to take care of themselves and the
Mhm.
baby and the family and get it all together. We want to sort of, keep their disease controlled, but also support their breastfeeding if they want to. So I think we are moving towards having a lot more knowledge about the safety of these medications and how to best phase things.
Mhm. And I think, the key is, with pregnancy and breastfeeding, one of the, top things that I talk to my patients about is have all the babies you want, but let's plan it. Okay.
Mm.
So we can have all the babies, right? I had one patient who had like 6 kids and she never went on therapy. She just kept having babies. And I was like, well, honey, if you can pay for them, then, more power to you. But, the key is planning, right? Particularly when we're talking about our disease modifying therapy. Sometimes there are adjustments that we can make where you maybe take a therapy and then, we say, okay, now at this point, it's safe to try to start conceiving. And then we'll go through this time period. And we just kind of check in and watch very closely. So I closely monitor my patients. We, say, this is the plan. We're going to start conceiving at, well, not we, you're going to start conceiving at this point in time. And then if we don't get pregnant by this point, then either we are, kind of checking back in to make sure you're not having symptoms, looking to see if we need to do another MRI, and then once we have the baby, we're making sure that we're checking in towards the end of that pregnancy to talk about plans for breastfeeding and things like that, et cetera. So there's a really close, monitoring with your healthcare provider, your healthcare team, but if at all possible, we want to try to plan, so that we're not caught off guard trying to figure out what to do with your medicines. If haven't been using contraception. And my savvy with contraception options has gotten much better as time has gone on. So we also have to have many conversations about different forms and methods of contraception as well, because I tell folks, if you are not trying to get pregnant, but not doing anything to prevent pregnancy, then you're trying to get pregnant. So if you're not doing anything to prevent it, then you're trying to get pregnant. So we have to have those conversations as well. Is there anything that you want to add to this piece of the conversation, Megan?
Yeah, so I think when you were talking about kind of planning the pregnancies, right? And I think another consideration is that some women do struggle to get pregnant. And so then bringing in fertility treatments and how that can play into, the timing of starting or stopping a DMT because of the use of fertility treatments as well. And, that's one piece. And then also kind of going back to, the breastfeeding aspect. I think what's also important is during this postpartum period, which is just challenging in general, even if you don't have a chronic neurological condition like MS. But I think also given the fact that MS patients are just more likely to develop depression, and then you have the risk of postpartum depression as well. And so, sorry, my office lights went off. But I think that's where also recognizing that, within the MS population, because they're at higher risk for depression, they need to be more mindful of potentially watching for postpartum depression during that phase. So even though they might have some protection with regards to relapses for lactation, they still are going to be at risk for that postpartum. And so they should be looking for that in addition.
Absolutely. And now that you said that, that kind of triggered something that I thought about in terms of overlap of symptoms. So we see this with pregnancy. We also see it with menopause, which we'll get into in the next few minutes. there are some symptoms that overlap, and with MS, for our patients, it often can be very difficult to figure out, well, is this the MS, or is this aging, or is this, or is this that? But some of the common symptoms that we see that can be exacerbated by pregnancy include urinary issues, right? So if you have a little bit of urinary urgency and now you got a nice little baby sitting on that bladder, that can make that symptom worse. We see fatigue can potentially get worse, and then of course, as you discussed, depression, things like that. So it's important to kind of, make sure that we balance those conversations. And again, for those who are watching who are living with MS or have care partners, or care partners who have a loved one with MS, it's important to kind of keep track of those things so that we can kind of sort what we think is really related to the MS versus what we think is related to, the condition of pregnancy or the postpartum period, etc.
And
So,
Mitzi, if I could
yeah, go
just
ahead.
hop in one additional
Absolutely.
symptom there, because I agree with you so much. I think sleep is just so critical, as we all know. Sleep is just so critical in the postpartum period, and sleep difficulties are one of the things that can really be associated with peripartum mood changes, anxiety, depression. So wherever possible, encouraging patients to get at least a good 4 or 5 hour chunk of sleep every night where they're uninterrupted is probably really key to that postpartum period as well, to sort of helping them feel rested and sort of emotionally a little calmer and better. So that's another symptom that's an overlap symptom, and that we really need to improve.
Absolutely. I wish I could have got a lot more 4-hour chunks of sleep. So we need to write prescription and say, dads, get up with the baby.
Support
Mom
system,
must
whatever
sleep.
it needs.
Let her sleep.
Mom must sleep 4 to 5 hours every night. So I will make sure I write that on a bunch of prescription notes and send that home with my patients. But all kidding aside, now let's switch gears and talk a little bit about menopause. So this is an area that we're learning a lot more about. Certainly when we think about MS across the lifespan, we know that kind of rates of MS are very similar in the adolescent period. And, during that, those childbirthing years, we see a much higher incidence in women than men, but then it kind of evens out again once we get past menopause. And then there also are symptoms that can overlap with MS symptoms. So let's talk a little bit about how MS is affected in that menopausal period. I'll start with Bradley.
Yeah, so you're right. So only about 10% of people are diagnosed after the age of 50, right? So if you think about that, it adds up to about 2/3 of all people with MS are diagnosed as premenopausal women. And half of all people living with MS are over the age of sort of menopause, people living with
Right.
MS currently. So
Right.
the menopausal transition is going to affect most people with MS will live through the menopausal transition, and a good chunk of people currently living with MS are postmenopausal. And so these are really important questions that you're
Absolutely.
right have not been addressed. And I think one reason was in the pre-MS therapy, pre-disease modifying therapy era, by the time people were 50, 55, and their MS was really starting to progress, menopause was sort of maybe an afterthought. It also was more taboo because, sort of one of those hush hush things we're not supposed to talk about. We're not supposed to think about as a normal transition where people need medical care. It was sort of, a stigma. And so now we're really kind of lifting the veil on it and thinking about it again as the normal transition that it is, but also really understanding the impact it can have on our patients with MS. And it really is, I would say, another time where patients really, really need us to sort of step up for them, to have, research, to understand what they're going through, and to give them some sort of warning about what's to come. So menopause doesn't affect everybody in the same way, and some people just, sort of glide right through
Breeze through it.
Marry a symptom, and good for them. But for many patients, I think the thing I hear the most is, I don't know if it's my MS or my menopause or what. And that like everything kind of comes together. The menopausal changes, kind of normal aging, and MS, and we see the overlap symptoms, like you mentioned, the difficulty with mood and sleep and bladder and cognition. And we also see the hot flashes are really bothersome. We know that heat bothers people with MS.
Absolutely.
And so those hot flashes are really bothersome. And together, it can really be quite a time where we can make a difference in people's lives, where we can help them with their symptoms and help them with the journey.
Absolutely. And what do we know about hormones in MS, right? So we know that it disproportionately affects women. There have been some studies in the past that have looked at hormones, but we haven't really identified if certain hormones put someone at increased risk versus another. How does that kind of tie into the menopausal period where people may begin to have hormone therapy? Does that affect their MS at all?
So hormone therapy, and Megan, jump in with your thoughts as well. I really love talking about this time period. So, but hormone therapy, it's very hard to understand about hormone therapy because, hormone therapy looked like it really had a lot of benefits for women. And then the Women's Health Initiative really, really just squelched that because it was a big trial, and they gave hormone therapy to menopausal women, but also much older women. And they saw some sort of concerning risk signals in the older women. And because of that, everything stopped. And today, the women with MS who've been followed sort of in modern cohorts, only about 15, 20, 25% of them are taking hormone therapy. And so we really don't know enough about, what that does. What I could say is from my patients who have had their hot flashes and menopausal symptoms managed, whether that's with hormonal therapies or non-hormonal therapies, they do just subjectively feel better when their symptoms are kind of brought under control, where they're sleeping better and not having those like bothersome hot flashes that interfere with their day. They do feel better, and they do feel like their MS symptom load kind of quiets down. So that, I think, is more anecdotal than objective at this point, just because we don't have a lot of numbers of research.
Yeah, and I'll chime in here and say, there was like a Danish registry analysis that was published not too long ago on kind of hormone therapy within MS patients. And I think one of the key outputs of this data set was ultimately that they didn't see an accumulation of disability. So it wasn't that the hormone therapy was like activating their MS and they were accumulating more disability as a result of it. So I think from that standpoint, it's at least encouraging to say, like, this has the ability to, as Dr. Beauvais said, control some of those unwanted, events that occur as a result of menopause just naturally, but without potentially increasing that risk for MS. Although, like she said, it increases other risks, like for cancers, which is where the greatest concern arose. But I think when we also think about hormones, just even in the pregnancy period, part of the reason that we see that decrease, in the relapse rate is because of the fact that we're changing the immune system, right? And so we see that decrease in kind of the pro-inflammatory cells and an increase in the anti-inflammatory cell populations. And so some of that is mirrored even as we age and we go through some immunosenescence, just that natural changing of our immune cells. And so some of that is going to play into the post menopausal period and leading to kind of some of that, shift from more relapses that they experience at a younger age, and more of that change towards the neurodegeneration that we come to expect in the later years with MS.
And I see a question in the chat. Are there any thoughts about bioidentical hormones? Is there a difference between those hormones and other forms of hormones?
Yeah, there are. And for people who are really interested in sort of hormonal therapy for their menopausal symptoms, I would really make sure that your doctors are familiar with the latest recommendations of the North American Menopause Society. So the North American Menopause Society, and by the way, they're changing their name so that they're not so US focused, but they come up with evidence-based guidelines every few years. And those are really important guidelines because they really show the latest guidelines really show that the risks of hormone therapy when it's given to menopausal women who are like, sort of peak symptom, those risks are really not as high as they were sort of purported to be in the Women's Health Initiative. And in fact, like for most people, the benefits outweigh the risk. And so you want to make sure that your doctors aren't shying away from the conversation just because they have old data. So I think that's one important thing. To your question specifically about the bioidentical hormones, they do have a position statement on that. And the idea of bioidentical hormones is kind of nice. It's sort of more hormone levels and hormone types that are sort of more similar to what we make on our own in our bodies. The problem with the way that they're given is they're not regulated as much at all. And so you don't really know what you're getting. You don't know the safety of what you're getting, and you don't know the dosage of what you're getting in the same way. And it's not as regulated or as evidence proven. And so while like the idea really resonates, and it does with me as well, I think that there's more safety concerns. And so I do kind of tend to caution my patients about those.
Right. And we do have to be careful, right? A lot of times when we are counseling our patients about different types of therapies, I know hormones may be one instance when we're talking about health and wellness supplements and things of that nature. It's important to make sure that you talk with your doctor about those things, but also to recognize that, even though when we think about medications that are very heavily regulated, the upside to that is that they are very well studied, right? So our traditional therapies are very well studied. We know the side effects, we know how they affect people. And so we have to just make sure that you're using caution and talking with your healthcare team about all these things. So, Megan, you touched on a word that I want to go back to, immunosenescence, right? So again, when we think about menopause and the transition period as we are maturing, most of our research studies end at the age of 55, which I always say is not old. Okay, let's be clear. It's not old. Right now, at my age, the only thing that's old is like 90. So if you're less than 90, you're not old. But one of the things that we're also concerned about is immunosenescence, which is kind of the aging of the immune system, like the rest of the body ages, And so it also kind of raises the question of what do we do about different therapies that affect the immune system, and how do we decide when the potential risks outweigh the benefits? What are some of the conversations that you have, Riley, with your patients kind of in that period? Or do you have conversations about immune system aging, in general, or only if someone is encountering some issues like infections or things like that?
Yeah. It's a really important conversation, and it's a really difficult conversation because there's really two sides, as you mentioned, to the story. So the one side is that we want to give people the most sort of effective, intensive therapy that they can handle for as long as possible to really give them every chance we have to control their MS. And on the other hand, we, as Megan mentioned, and also just as we've seen with the COVID pandemic, clearly with aging, the immune system becomes less robust and more fragile. And so I've been in situations where, on one hand, people say, well, we really have to be very, very careful in aging people. And on the other hand, people say, well, you can't be ageist, don't deny someone effective therapy. And so you're kind of trying to balance, the risks and benefits. And so I think the conversation, Mitzi, you mentioned before, sort of like the conversation and the shared decision-making piece. And at every step, it's shared decision making, talking about the risks of infections, the risks of unknowns, right? We were all sort of like woke up kind of February 2020 and just, like terrified that, about what was going to happen to our patients on immune suppressive therapies, right? Or immune modulatory therapies. We're all just terrified because you don't know what the next pandemic could be or what the next virus could be. But I think sharing what the knowns are and then asking people, how aggressive they want to be.
Mm-hmm.
And I think one of the silver linings of menopause actually is that the risk of relapses tends to decrease after about the age of 50, 55. So one silver lining is that patients may not need as aggressive therapy to prevent new lesions and new relapses. And so that's sort of like, kind of helps us maybe thinking about treatment de-escalation.
Mm-hmm.
But that treatment de-escalation question is a really, really interesting one. And we can only rely on real world data for the most part, because as you said,
Right.
most trials just stop at age 55.
Mm-hmm.
Thankfully, it's starting to change.
Yeah, absolutely. And I think, again, there are lots of questions that need to be answered, but I think the key is shared decision making, sitting down with the healthcare provider and the patient and talking about kind of what are the risks and benefits. There's a couple of large clinical trials that are trying to look at what happens in the real world. And if we should stop therapy after a certain age. I don't necessarily tend to stop therapy at a certain age, but if my patients start to have issues like they start having a bunch of urinary tract infections or colds that we can't get rid of, then that certainly can spur a conversation about maybe we need to adjust therapy. And again, those are things that people can look out for. Is there anything you want to add about immunosenescence, Megan?
Yeah, well, I was also going to add, in addition to kind of being mindful of the infections that patients are having as they age, it's also about comorbidities, right? So
Absolutely.
as you age, things just don't quite work the way they did in your 20s, right?
Oh, don't I
And
know it?
so now you have to potentially be managing, other therapies that the patient might be on and how
Right.
that could play into the DMT that you're choosing for that patient to either remain on or switch to as well. So, that's another consideration for these, advanced aged patients as they, continue through this journey.
Absolutely. How can we better, or what gaps do you see that need to be addressed in looking at women's health needs across the lifespan, kind of in general, and then specifically with MS? Go back to you, Megan.
Sure. Thanks, Mitzi.
Hmm.
Well, there's a lot because
There's
I
a lot.
think really there hasn't been as much research in this area. And so it's something that we definitely need to continue to have these conversations to drive, research in this area overall. And so obviously understanding how patients could potentially remain on therapies and which therapies they could remain on during that pregnancy or during the lactation period. For some of the DMTs, like the Copaxone or the interferons, there's a lot of data, but for some of the other DMTs, which are, maybe more new, there's just not much there. And so really appreciating and understanding how to get that data set moving forward. And I know this is something that Riley actually published a poster at AAN with us, looking at kind of the postpartum relapse rate, but also looking at the DMT utilization, how it changed over the different trimesters of pregnancy. And then I would say for, menopause, again, it's something that we just don't have a lot of data to understand the hormone therapy use, as well as, how underserved patients may be different than the Caucasian patients, which drive a lot of the data sets that we've seen thus far. And so I would say, those are some of the key areas that we need to continue to push and educate on with regards to these.
Absolutely. Riley?
Yeah, those I agree with you, Megan. Those are important things. I think a couple other things about sort of kind of models of care
Mhm.
that, I think a lot about. So if we think about anticipatory planning, like giving patients information about the next phase, like what do you expect before a pregnancy? What do you expect during a pregnancy? What do you expect postpartum? I find that, my lab has contributed work to the breastfeeding question. We've contributed work to the postpartum rehab needs and postpartum depression question. And I bring it up with my patients and I say, by the time you're postpartum, you want to have your MRI scheduled and your PT and your pelvic floor PT scheduled so that you're not trying to get your insurance authorizations or scheduling when you're also learning to take care of a newborn, right? You want to have this, everything you can plan just out of your hands so that you're just spending time with your baby and going to your appointments. And they'll agree and we'll have a plan. And then it's really, really just hard for them to get done everything they need to get done because MS is such a burden, right? Like in terms of there's just scheduling and ordering and things. And so how to make those transitions easier for patients, I think is something that, I struggle with a lot, and how to make sure that patients have coherent plans of care. I just saw a patient the other day. We talked all about my lab's research on sort of medication safety during lactation, and I put citations and I explained it, and I talked to her OB. And then she had a couple covering OBs and a couple sort of other healthcare sort of, clinicians involved in her care who kind of made her rethink everything again. And of course, we want people to think about things critically, but just kind of not stirring the pot and making it more difficult when people have committed to a plan of action, and just making sure that we're not confusing the message, because there's just so much to think about at that time. So that's one thing. And I think with menopause, I really wish we started the conversation, a good 5 years before people might expect, to have their final menstrual period. So if people's final menstrual period, sort of the median age, half of people reach their final menstrual period by around age 51 with MS. So maybe starting at around age 45, saying, you may not hit your menopause for 5 years, 10 years, but you might experience these symptoms. You might experience, hot flashes bothering your MS. You might experience some of these overlap symptoms, and it's okay. We'll treat it. You'll do okay. We'll get through it. We just need to see you a little more frequently and to tag team with your primary care doctor and get you over this. And I think that if we could really guide patients and anticipate a little bit more, it would really help them. It would just really make it easier. So that's a big thing.
Yeah. So we got a lot of work that we need to do, it sounds like. Well, in that vein, tell us about any initiatives or projects that you're excited about kind of going on in this space. And I'll go back to you, Megan.
Sure. Yeah. So like I mentioned, at AAN, we published a couple of posters with Riley as, an author. So thank you, Riley, for participating. Because we do recognize that, there is very limited data when it comes to pregnancy and even the postpartum. And similarly, we're also working with Riley on a postpartum depression study with her and Dr. Houchins. So that's always exciting. We just had the readout of kind of our tech registry for pregnancies and understanding the outcomes that these patients as well as their infants had with regards to exposure to Tecfidera. So that's really exciting work. And I know we're also working with Dr. Houchins in particular, looking at lactation, whether or not our therapies are crossing through the breast milk. And so, that's really important for that time period. But I think also we have a lot of initiatives going around health equity and understanding how all of these different racial and ethnic backgrounds are impacted by their MS disease and across their lifespan, as well as trying to gather more information about the LGBTQ community, because it's challenging. We're not necessarily collecting that data in registries quite often, and a lot of times it's not collected within the claims databases. And so trying to find those patients to be able to generate more information in that area is something that, we're looking to do. So, we're excited to see where these questions go, and, partnering with all of you. I know, Mitzi, you guys have your National African American Registry, which we, are very excited to see what we can potentially learn from that as well.
Absolutely. What about you, Riley? I know that you're deeply entrenched in this work. And I remember, when I first met Riley, I just remember you were having conversations with one of our colleagues from New York, Claire Riley, about breast milk. And I just remember these two ladies saying, like, did you get the breast milk? I sent the breast milk. We sent the breast milk. But I think it's so exciting because these were conversations that we weren't having, 5 or 10 years ago. So tell us about some of the work that what you can disclose about some of the work that you've had going on.
Absolutely. I mean, when I started trying to do menopause and MS research, when I started some of the projects, about 10 years ago, it was really hard to get funding. It was really hard to get interest. A lot of the key opinion leaders said that it wasn't an issue, that it didn't matter. And a lot of the sort of try to get grants, people said, well, you don't have prelim data. And I said, exactly, like we
how
need
do I get the data? It doesn't exist.
We need to do
I've
this.
got to generate it.
We don't know. And so I'm really encouraged to see the field has changed a lot. And I think, having industry players really supportive, as you mentioned, Megan, supportive of this research, supportive of research that matters to our patients, I think is really key. That we all kind of, come to the table, that we don't just sort of like turn an sort of a blind eye on patients when they're kind of most needy of care, that we really try to address, look at this question, I think is so important. And so I've seen that as a huge change. And I don't know if you agree, Mitzi, but just sort of seeing, industry really kind of step up and support these efforts for patients and for us as researchers. And then I think I'm really excited about the lactation work because I think it can help new families in many ways. So I'm very excited about that. And with menopause, actually, there's a sort of the news flash, hot flash, is that there's a new medication approved just 2 days ago that's a non-hormonal therapy for menopausal symptoms. So for people for whom hormone therapy may not be safe or okay, there are non-hormonal therapy options as well. So that might be great for some of our people with MS to kind of help kind of stabilize them. I'm very excited to see how that plays out in the MS field.
Awesome. Well, it sounds like there is a lot of amazing work going on. And, I'm just so excited, for the field, but mostly excited for people living with MS because, now we're able to learn about these things. We have researchers who are passionate about this work and about helping us to make sure that we are treating, the vast majority of our patients who are women of childbearing ages and women who will go through menopause. So I think that this is very exciting that we're now getting to the point where we're looking at real world data and that we're trying to better understand how to serve our patients' needs throughout their whole life with MS. The goal is for people to live well with their MS across their whole lifespan, not just when they're finishing college, but when they're in their 50s and 60s and going through that postmenopausal period. So I'm very excited about all the work that's being done. So any parting thoughts that you want to leave with our viewers before you leave? Any advice you would give to a woman who's watching this, who's living with MS, and kind of thinking about different transitions in the lifespan?
I can take that first.
Go ahead.
I would say my biggest piece of advice is that don't be afraid to ask questions, right? You have to trust in your care team. And if you're not raising the questions to them, you're never going to get the answers. And so, my advice would be ask those difficult questions, even if it feels, uncomfortable, they're not going to be able to help you if you don't ask the question. So that'd be my piece of advice.
Absolutely. What about you, Riley?
I think, if you think about, you said something earlier, Mitzi, about that you'd become like really, adept at sort of the contraception, thing. So if you think about what we're trained to do as neurologists, right, we're not like so much trained to think about the breast milk story or sort of like IUD, insertion or kind of, bladder. We're not necessarily trained very well in all the pieces of women's health, all the dimensions of women's health in MS, and certainly not the neurologist for whom it may not be sort of a research or care passion, right? And so to go with Megan's really important point, which is you have to trust in your care team, just like you would ask your doctor for perhaps a referral or a second opinion or some added insights for any other aspect that they were not an expert in, whether it's going to see a urologist or going to see a PT or anything else. If your doctor doesn't know the answers when you ask, you deserve to get those answers anyway. And so they can't just say, it doesn't matter, ask for a referral or ask for additional expertise, because there is expertise and there is evolving knowledge, and patients deserve to have access to it.
I love it. And my advice is always, you are your own best advocate, so don't be afraid to ask those questions if you're not getting what you need. It's okay to seek a second opinion. It's okay to seek a third opinion, but make sure that, the issues that you're having are being addressed. And that is for those care partners as well. Well, this has been an amazing, amazing conversation. We got it in. Now we could have gone a little deeper into all of those things, but I really appreciate both of your time and expertise in coming on Brain Chat today. Thank you for all of those who took your time out today to view. And thank you to our sponsors, Biogen IDEC and the National MS Society. Have a great night, everyone, and we'll see you on Brain Chat in 2 more weeks.